Another congenital malformation which is commonly seen in these children is a small left colon. So what is small left colon? Now here what happens is the nerve supply of the colon, there is delayed innervation. So there is not the normal time at which the colon should have been innervated. That does not occur. There is delayed innervation of the colon. So immediately after birth, this colon will not be able to contract. And when the colon will not be able to contract, the meconium which is present inside the intestine will not pass. So this is one of the possible causes of child not passing meconium after birth. One of the possible causes. What is this called? This condition is known as a small left colon, also sometimes called as a lazy left colon. So I'll repeat again. What are the congenital malformations that are seen in infant of diabetic mothers? Congenital heart defects, neural tube defects, caudal regression syndrome, and a small left colon or a lazy left colon. The most common congenital heart defect in these children is VSD, ventricular septal defect. Least common heart defect is ASD, atrial septal defect. And the most specific congenital heart defect is transposition of great arteries, TGA. Neural tube defects, most common single complication infant of diabetic mothers, neural tube defects. Caudal regression syndrome, most specific complication infant of diabetic mothers. Caudal regression syndrome is also known as sacral agenesis. Sacral portion of the spine is underdeveloped. And the last congenital malformation is delayed nerve supply of the colon, which is also known as small left colon or a lazy left colon. So these children do not pass meconium after birth. So complication with L, large for gestational age. Complication with C, low cost MRP. Complication with C is congenital malformations. Then MRP. So what are the complications associated with MRP? So let us see M. So M, you have two metabolic complications. The first metabolic complication is hypoglycemia and second metabolic complication is hypocalcemia. And I have told you yesterday, did I mention about neonatal hypoglycemia and hypocalcemia yesterday in my class? Yes, when I was talking about IUGR and preterm. I told you in both preterms and IUGR, neonatal hypoglycemia and neonatal hypocalcemia are commonly seen. I also told you the definitions of neonatal hypoglycemia and hypocalcemia. Hypoglycemia in a neonate is blood sugar less than 40 milligrams per deciliter, and neonatal hypoglycemia, hypocalcemia is serum calcium less than 7 grams per deciliter. I told you both definitions yesterday. Hypoglycemia in a neonate and hypocalcemia in neonate are also seen in infants of diabetic mothers. So they are also metabolic complications in infants of diabetic mothers. Right? Then R, MRP. So what are the complications that are seen in terms of R? It is respiratory disorders. So the two respiratory disorders which are complications seen in infant of diabetic mothers is the hyaline membrane disease. I'm sure you have heard of this condition. This is a disorder which occurs because of lack of surfactant. And we'll talk about this disorder. Another disorder which is associated with transient breathing difficulty after birth and is commonly seen in infant of diabetic mothers is a condition known as TTNB, transient tachypnea of the newborn. As the name suggests, it is only a transient tachypnea. Transient fast breathing. It is not fast breathing which continues. So it is something which is not dangerous disorder. Unlike hyaline membrane disease, which is a highly dangerous disorder, this is not a dangerous disorder. Both of them are respiratory disorders which are associated with breathing difficulty after birth. So one is hyaline membrane disease and one is transient tachypnea of the newborn. These are disorders which are respiratory disorders. So MRP. And what is P? P stands for polycythemia. P stands for polycythemia. Please just try to understand what I am saying. Children who are born to diabetic mothers, please hear carefully what I am saying. Children who are born to diabetic mothers, the first complication I told you are large for gestational age. So the fetus is very large. The uterus is small. So when the fetus is very large and uterus is small, the fetus will have lack of space in which to grow, so he will start having hypoxia. And because of hypoxia in the fetus, there will be increase in RBC production. So that leads to polycythemia. So what is polycythemia? Polycythemia is increase in the RBC production. And this increased RBCs, when they thrombose inside the renal vessels, it can lead to renal vein thrombosis. And this increased RBCs, when they break down, they can lead to the release of bilirubin. So jaundice again in newborns is very common in children who are born to diabetic mothers. So both renal vein thrombosis and jaundice are complications of polycythemia in infants of diabetic mothers. Right? Renal vein thrombosis and jaundice. So I'll again repeat. L stands for large for gestational age. C stands for congenital malformations, which includes congenital heart defects, neural tube defects, caudal regression syndrome, also known as sacral agenesis, and a small left colon or lazy left colon. The most common congenital heart defect is a ventricular septal defect. Least common congenital heart defect, atrial septal defect, and the most specific congenital heart defect is a transposition of great arteries, all of them in infant of diabetic mothers. The most common complication in infant of diabetic mothers is a neural tube defect. The most specific complication in infant of diabetic mothers is a caudal regression syndrome or sacral agenesis. So the sacral part of the spine is not properly developed. Another complication in which the child does not pass meconium after birth is a small left colon or a lazy left colon, again seen in infant of diabetic mothers. The complication which starts with M, metabolic complications, are hypoglycemia, which is defined as blood sugar less than 40 milligrams per deciliter, and hypocalcemia, which is serum calcium less than 7 grams per deciliter. The complication which starts from R, MRP, R is respiratory disorders. So respiratory disorders seen in infant of diabetic mothers, one is hyaline membrane disease, which is because of lack of surfactant, and the second is a transient breathing difficulty after birth in a newborn, which is known as transient tachypnea of the newborn. And the complication that starts from P is polycythemia. And polycythemia is because why? Because a large baby inside the uterus will have hypoxia, and when there will be hypoxia, there will be increase in the RBC production. Increase in RBCs is what is known as polycythemia. It can form clots in the renal vessels. That is why renal vein thrombosis. And these large number of RBCs, when they break down, they will release bilirubin. That is why jaundice is also very commonly seen in these children. So very quickly, let us see. I don't think there is any need to write this now. Don't write this. We are just trying to recollect whatever we have already done in infant of diabetic mothers. So which is the most common system involved in infant of diabetic mothers? It is the cardiovascular system, not the nervous system. Which is the most common congenital heart defect in infant of diabetic mothers? I told you it is ventricular septal defect. Please don't write this. This is not required. It's just what we have already studied in infant of diabetic mothers. Which is the most specific congenital heart disease in infant of diabetic mothers? It is transposition of the great arteries. Which is the least common congenital heart defect in infant of diabetic mothers? It is atrial septal defect. Which is the most common complication in infant of diabetic mothers? It is neural tube defect. And which is the most specific complication in infant of diabetic mothers? It is caudal regression syndrome, also called as sacral agenesis. So these are questions that can be asked in the exams. And the moment they ask a question in the exam from any of these, you should be able to answer. Right? Okay. Now, a few pictures that I would like to show you, which are pictures of some benign problems that are seen in newborns. You should be able to, if a picture is asked in the exam, you should be able to identify what this problem is and when does it usually get corrected. Sometimes you can see white colored spots which are present in the face of a newborn, usually over the nose. See the first picture. these white spots are distended sebaceous glands, and this is known as milia. So what are milia? Milia are distended sebaceous glands seen over the face, particularly over the nose, and usually do not require any treatment. They will usually disappear on their own. What is it called? It is known as milia. Now this is one of the FMG questions. Sometimes you can see a white colored spot over either the palate, or it can be seen on the gums also. You can see in the second picture, you can see a small white cyst which is present over the palate. What is this white cyst called? It is known as an Epstein pearl. Epstein's pearls are retention cysts. What are Epstein pearls and Bourne nodules? They are retention cysts. They are retention cysts. But when this retention cyst is present over the palate, it is known as Epstein pearl. When it is present over the gums, it is known as Bourne nodules. You can see over the gum a white colored cyst. So when it is present over the gums, it is known as Bourne nodules. So both Epstein pearls and Bourne nodules are actually retention cysts. But when these retention cysts are present over the palate, it is known as Epstein pearls. When these retention cysts are present over the gums, here you can see over the upper gum, then it is known as Bourne nodules. Right? And both of them do not require any treatment. And what are milia? Milia are distended sebaceous glands present over the face, particularly present over the nose. Then this is another thing that you need to know. Red colored rashes, normally they are yellow pustules or yellow colored spots which are surrounded by redness. They usually never appear on day one, and they never reach palms and soles, and they usually disappear by 1 to 2 weeks. What are these rashes called? These are the most common rashes that are seen in the neonatal period and is known as erythema toxicum. Erythema toxicum are yellow colored spots which are surrounded by redness. So usually basically you will see redness all across the body of the child, and they can be present anywhere in the body, almost anywhere in the body, but usually do not reach the palms and soles. So palms and soles do not have it. In fact, we always learned this, that if you have redness in the palms and soles of a newborn, do not think of erythema toxicum. This is not erythema toxicum. And usually they disappear by 1 to 2 weeks. They will never appear on day one. They normally appear from second to third day, maybe a little later, but will gradually disappear on their own by about 1 to 2 weeks. You do not require to do any treatment. When scrapings are taken from these rashes and they are seen under the microscope, these rashes appear to be made up of eosinophils. So what are these rashes appear to be made up of? They are made up of eosinophils. So yesterday when I was seeing the FMG question, there was one question, a child who is day 3 develops rashes. Please hear carefully what I am saying. A child who is day 3, third day after birth, develops redness over the face, over the chest, over the abdomen, and over the upper half of the extremities. The child appears to be otherwise normal. Scrapings from these rashes are taken and seen under the microscope. What type of cells will be most commonly seen in these scrapings? A. Basophils, B. Monocytes, C. Eosinophils, and D. Blasts. So what will be the most common cells seen? Eosinophils. These rashes appear to be allergic rashes. Allergies to unknown allergen. We do not know which is the allergen actually to which these rashes occurs in some newborns. But this is the most common erythematous rash of a newborn. 7 out of 10 rashes in newborns appearing on 3rd or 4th day or 5th day are likely to be erythema toxicum, especially if the child otherwise is absolutely normal. A child who is sick and who is having these rashes, do not think of erythema toxicum. Erythema toxicum is in a normal healthy child. They never appear on the palms and soles. They can appear everywhere in the body but never on the palms and soles. And they will disappear by 1 to 2 weeks. The scrapings will always show eosinophils. Mongolian spots. These are bluish colored rashes which can be seen again on many parts of the body, but usually most common site of Mongolian spot. This again is an FMG question. Which is the most common site of Mongolian spots? It is usually over the lumbosacral area. So most of the Mongolian spots usually are seen in the lower part of the lumbar area, lower part of the back, the lumbosacral area. So what is the most common place where Mongolian spots appear? In the lumbosacral area. And these Mongolian spots, they usually disappear by 1 year of age. So do you do any treatment for Mongolian spot? Again, a question of FMG. Is there any treatment required for Mongolian spots? Answer, no treatment is required. Mongolian spots will disappear on their own. So you do not require to do any treatment. What is the most common site where they appear? It is the lumbosacral area. Then swelling, which is present over the head of these children, newborns, can either be a caput secundum or it can be a Keffel hematoma. So one can be a Keffel hematoma and one can be a caput secundum. So what is the difference between a caput secundum and a Keffel hematoma? Please see. Any swelling which presents immediately within a few hours of birth, usually within 12 to 24 hours, and it disappears very quickly within 2 to 3 days. Fast appears and fast it disappears. It is likely to be a fluid collection, and this is known as a caput secundum. On the other hand, a Keffel hematoma has a delayed appearance. It's a blood collection. Normally, when you are trying to forcibly extract the head of the child out, when the child is not able to have a proper head delivery, so you try to use forceps and extract the child out. Because of that, there can be trauma in the head, leading to Keffel hematoma. Hematoma is blood collection in the scalp. Unlike caput secundum, which appears within a few hours of birth, Keffel hematoma unlikely to appear in the first 24 hours. It always is a swelling in the head which is delayed. And the swelling, unlike caput secundum, which disappears in 2 to 3 days, this swelling of Keffel hematoma may take almost around 6 weeks to disappear. So any swelling which is persistent in almost around 6 weeks is unlikely to be a caput secundum, more likely to be a Keffel hematoma. If you are still confused, just pass your hand over the swelling. Just pass your hand over the swelling. If the swelling crosses the suture lines, it is likely to be a caput secundum. If the swelling does not cross the suture lines, that means it comes till the sagittal suture, for example, and the swelling finishes here. Then on the other side, swelling starts again. This is likely to be a Keffel hematoma. So two types of swellings. One is known as caput secundum. Other is known as Keffel hematoma. Caput secundum is usually a fluid collection. Between the skin and periosteum. So basically it's a fluid collection in the scalp, usually between the skin and the periosteum. Keffel hematoma is basically a blood collection between periosteum and the bone. It's a blood collection. It's not a fluid collection, Keffel hematoma. Caput secundum appears within 12 to 24 hours. So this swelling will appear very quickly within 12 to 24 hours and will disappear also very quickly by 2 to 3 days. So any swelling that has appeared in the scalp and has disappeared in 2 to 3 days, it is unlikely to be a Kefel hematoma. It can be only a caput secundum. In the case of a Kefel hematoma, this swelling appears late. It never appears at least in the first 24 hours. It will take time to appear, and it is also known to take time to disappear. It normally disappears in 3 to 6 weeks. So mother says, doctor, I saw a swelling in the scalp of my newborn, and this is now almost 3-week newborn, and the swelling is still persisting. It is unlikely to be a caput secundum because only a Kefel hematoma can stay that long. 3 weeks to 6 weeks taking time to disappear. In fact, this is a PG entrance question. What is the time when Kefel hematomas normally disappear? They normally disappear by 3 to 6 weeks. Last difference, caput secundum, because it is a swelling over the periosteum. Therefore, caput secundum, the swelling crosses the suture lines. Crosses the suture lines. On the other hand, a Kefel hematoma, because this is a swelling, blood collection below the periosteum, it does not cross the suture lines. So this is what you need to know for your exams. Caput secundum, Kefel hematoma, both of them are swelling of the scalp. But based upon whatever I have told you, you will be able to differentiate whether this swelling is a caput secundum or this swelling is a Kefel hematoma. Any swelling which appears very quickly over the scalp, mother says, doctor, yesterday the child was delivered, yesterday evening and today morning I am seeing a swelling. A Kefel hematoma cannot develop so fast. So this is a caput secundum. By second to third day, you see the swelling has disappeared completely. This is a caput secundum. Swelling appears for the first time on the third day, on the fourth day. This is a Kefel hematoma. It's been almost 1 month, 1.5 months. The swelling is still persisting. It is a Kefel hematoma. Just pass your hands over the swelling, and the moment a suture comes, say the sagittal suture or the bitopic suture, the swelling disappears. This is a Kefel hematoma. It will not cross the suture lines. But a caput secundum, it is crossing the suture lines. The most common reason for a Kefel hematoma, because it's a blood collection, it is trauma. In some cases, the head of the child is so big that during the time of delivery, you may require a forceps to forcibly extract the child's head out, and that may lead to bleeding in the scalp. That will lead to what is known as a Kefel hematoma. Right? So I hope you have understood this. Okay. Then coming back to the slides, it's again quite common for the female newborns to have some amount of vaginal bleeding on day 3 to day 7. And the most common cause of this vaginal bleeding is withdrawal of the maternal hormones, especially the estrogen. So withdrawal of the maternal hormones, especially the estrogens, can lead to some amount of bleeding through the vagina between day 3 to day 7. Please remember, any bleeding that appears after the first week, this is very important. Any bleeding through the vagina in a newborn which appears after the first week needs to be investigated. It is only a bleeding which appears between day 3 to day 7 in the female newborn through the vagina, which can be considered normal and a consequence of withdrawal of the maternal estrogens. So you do not need to do any intervention for that. So as a doctor, if the mother comes to me with this complaint, doctor, I was changing the diaper of my child and I could see some blood spots which were present in my female newborn, the first question I would ask was, what is the age of your child? Mother says, doctor, she's day 3 or she's day 5 or she's day 6. It's likely that this is a normal physiological bleeding because of withdrawal of the maternal hormones. But any bleeding which occurs after day 7 needs to be investigated. It can be anything. Again, there was a question in your FMG on the terms and preterms. So how do you identify whether this child is a term child or a preterm child? This table should help you remember. The skin of a term child usually is dry and it is pinkish in color. In comparison to the skin of a preterm child is very smooth and is shiny. So when you are overall seeing the child's skin, you can identify whether this child is a term or a preterm child. The term child skin is actually very dry, parchment-like, and it is pinkish in color. On the other hand, the preterm child skin is very smooth and is shiny. Another way of finding out whether this child is a term or a preterm child is just press the ear. So when you press the ear and see how fast the ear recoils. So if you press the ear and there is immediate ear recoil, this is likely to be a term child. But if you press the ear and it takes time for the ear to gradually go back, then it is slow ear recoil, likely to be a preterm child. If you are still confused, just see the sole creases. This is the sole. Sole is the underside of the foot. So if there are deep creases that can be seen in the sole, this is likely to be a term child. But if there are only superficial creases or absence of the sole creases, it is likely to be a preterm child. So deep sole creases that can be seen is a term child. So this is basically the sole of a term child. You can see how deep the sole creases are, while this is basically a preterm child. Because you can see only superficial sole creases. Then lanigo are the hairs of a newborn. So very scant or absent lanigo, which are hairs of a newborn present over the body, this is likely to be a term child. While there are abundant lanigo, it is likely to be a preterm child. So what happens is this lanigo hairs can actually be seen to be present in plenty of amount in the case of a preterm newborn. What happens is by around 28 to 30 weeks, they start to disappear. So the earlier the preterm is born, the more lanigo which will be present. Less lanigo or less hairs present over the body, this is more likely to be a term child. Finally, breast buds. Breast buds, just see the diameter of the breast buds. So if the diameter of the breast buds is between 5 to 10 millimeters, it is likely to be a term child. If the breast buds are very small, which is less than 5 millimeters, it is likely to be a preterm child. Right? So these are some important differences between the term and a preterm newborn. So first, see the skin. If the skin is dry or pinkish in color, it's likely to be a term child. If the skin is smooth and very shiny, it is likely to be a preterm child. Press the ear and see the ear recoil. If there is instant ear recoil, it is likely to be a term child. If there is a very slow ear recoil, it is likely to be a preterm child. Just see the underfoot, soles. And if there is a plenty of sole creases, deep sole creases, it is likely to be a term child. If there are only superficial sole creases or absence of the sole creases, it is likely to be a preterm child. Then the hairs of a newborn are known as lanigo. So plenty of hairs which are present, it is likely to be a preterm child. Hairs are scant or absent. You can hardly see hairs over the newborn. The preterm hairs, the infant hairs, the fetus hairs, they are likely to be term child. So what are the fetus hairs called? They are known as lanigo. So if there is absence of these hairs or very few hairs present, it is likely to be a term child. If there are plenty of these hairs present, the fetus hairs, then it is likely to be a preterm child. And finally, measure the diameter of the breast buds. If the diameter of the breast buds are about 5 to 10 millimeters, then it is likely to be a term child. If the diameter of the breast buds are less than 5 millimeters, it is likely to be a preterm child. So I hope you have seen what are being used for differentiating a term for a preterm child. You have seen this difference. So now let me discuss it like this. So what differences, what were the criteria that you actually saw in that table which were used to differentiate a term and a preterm child? What were the criteria that you actually used? So the first criteria that we used was skin. So pinkish in color, dry, term child, smooth red, preterm child. The second criteria I think that we used was ears. So ear recoil instant, term child, slow ear recoil, preterm child. The third criteria was soles. So plenty of sole creases, term child. very superficial soul pleaser, absent soul pleasers, preterm child. The fourth was hairs, which is Lanigo. So abundant hairs, preterm child, very scant hairs, term child. And the fifth criteria that we actually saw was the breast buds, the size of the breast buds. Right? So now the FMG question that was asked. So the FMG question that was asked was this question. So what was the FMG question? The FMG question that they asked is, again, all of these criteria can be used to differentiate a term from a preterm child, except, so which is not used criteria. And what were the options? I'm sure now you will be able to answer. The first was ear, the second was eyes, the third was skin, and the fourth was Lanigo. So which of these four criteria is not used to differentiate a term from a preterm child? I think it is pretty simple. The criteria that is not used to differentiate a term from a preterm child is eyes. Ear is used, skin is a criteria is used, Lanigo is a criteria is used, but eye is a criteria is not used to differentiate a term from a preterm child. So I think this is now pretty simple. You'll be able to answer any question based upon the differences in a term or a preterm child. So the criteria that are primarily used are skin, ear, soles, Lanigo, and the breast buds. Right? Okay. So before we take a break, uh, let us quickly revise what we did since today morning. So today's class I started first by revising whatever I did yesterday. Then I talked about umbilical cord. I told you an umbilical cord has two umbilical arteries, one umbilical vein. Then I also told you that an umbilical cord normally falls by 7 to 10 days. In case there is a single umbilical artery in the umbilical cord, the first defect that you should think of is a congenital kidney disorder. Other defects can be congenital gastrointestinal tract disorders or congenital heart defects. An umbilical hernia, if it forms, nothing to worry. It normally resolves on its own. However, if the umbilical ring is more than 1.5 centimeters, after 2 years, it is one of the indications for a surgery. Then we also discussed about complications which are associated with congenital diaphragmatic hernia in infant of diabetic mother. So what is a diaphragmatic hernia? Abdominal content herniating through a defect in the diaphragm into the chest cavity and therefore compressing the lungs. The most common maternal pregnancy complication, polyhydramnios. The shape of the abdomen, scaphoid, boat-shaped abdomen. Scaphos means boat, so scaphoid abdomen is boat-shaped abdomen. Which is the most common cause of death? Pulmonary hypoplasia and pulmonary hypertension, which keeps on persisting in these children even after birth. That is why it is also known as persistent pulmonary hypertension of the newborn. Now, 75% of diaphragmatic hernias are on the left side and posterolateral. So this type of hernia is known as a Bogdalek hernia. About 20% of hernias are anterior and on the right side. Those are known as the Morgagni hernias. Only about 2 to 3% are central hernias. Then what is the management? First, intubate. Diaphragmatic hernias, please remember bag and mask ventilation contraindicated. Intubate, nasogastric tube to decompress the stomach, and finally surgery which can be performed at 48 to 72 hours. Then I talked about infant of diabetic mothers, complications. Low cost MRP was the mnemonic. L, C, MRP. L, large for gestational age. C, congenital malformations. M, metabolic complications. R, respiratory disorders. And P, polycythemia. Most common organ system involved in infant of diabetic mothers, cardiovascular. Most common congenital heart defect, ventricular septal defect. Least common congenital heart defect, atrial septal defect. Most specific congenital heart defect, transposition of great arteries. Then I also talked about most common single complication, neural tube defects. Most specific complication, so it's just playing with words. Most specific complication is caudal regression syndrome or sacral agenesis. And I also talked about delayed nerve supply of the colon in these children, which is also known as small left colon or lazy left colon. Metabolic complications, hypoglycemia, hypocalcemia. How do you define hypoglycemia? Blood sugar less than 40 milligram per deciliter in a newborn. How to define hypocalcemia in newborn? Serum calcium which is less than 7 grams per deciliter. Which are the respiratory disorders I told you which are common in these children? Hyaline membrane disease, transient tachypnea of the newborn. And polycythemia, which is a result of hypoxia, can lead to renal vein thrombosis and can lead to jaundice. Then I told you I showed you some pictures, some common benign problems which are seen in newborns. So retention cysts seen over the palate of a newborn is known as an Epstein pearl. Retention cysts seen over the gums, Vaughan nodules. Distended sebaceous glands over the face, milia. Most common erythematous rash in the neonatal period, erythema toxicum. The scrapings will show eosinophils under the microscope. Normally appears by around day 3 or day 4 and will disappear by 1 to 2 weeks. So you do not have to do anything. The child otherwise will be absolutely healthy, accepting feeds normally. So this is a complication. This is not a complication. This is a disorder which you do not need to worry about. Mongolian spots, bluish colored spots, commonly seen in the lower part of the spine of the back, lumbosacral area. Normally disappear again on their own, so you do not require to do any treatment. Timing that it disappears 1 year. Then we saw scalp swellings, which can be either a caput secundum or a Keffel hematoma. Swelling which appears very early, caput secundum, and disappears also in 2 to 3 days. Swelling which appears late, Keffel hematoma, and disappears in 3 to 6 weeks. Swelling which crosses the suture lines, caput secundum. Swelling which is limited by the suture lines, does not cross the suture lines, is Keffel hematoma. And finally, we also talked about differences in a term and a preterm child. So skin, pinkish in color and dry in a term child, red in the case of a preterm child, very thin red skin. Then ear recoil, instant ear recoil in a term child, very slow ear recoil in a preterm child. Then sole creases, plenty of sole creases in a term child, very superficial absent sole creases in a preterm child. Then lanigo, hairs, plenty of lanigo, preterm child, scant or absent lanigo in the case of a term child. And finally, size of the breast buds, 5 to 10 millimeters in the case of a term child and less than 5 millimeters in a preterm child. There are some more differences, but eyes definitely cannot be used to differentiate a term from a preterm child. Right? So with this, we take a break, 15-20 minutes break. After the break, there are some more disorders which are related to neonatology that we'll do. After which we'll start the third chapter, which is congenital heart disease. I hope you are enjoying the class and you find the class comfortable. Any questions you can give at the end of the class. You can accumulate those questions. You can type in the inbox, and I'll be happy to answer those questions.